we talk about minimally invasive surgery for brain tumors, this is a broad category, and and people often market a procedure as minimally invasive because it sort of has appeal to patients. But there's no formal definition in the neurosurgical literature, but we can rely on the National Cancer Institute, which encompasses cancer surgeries, systemically beyond, well beyond the numbers we see in the neurosurgical world. And the definition there is just surgery done through small incisions that are smaller than what has historically been used for similar pathologies. And so in brain tumors, this can be a spectrum ranging from burr hole type corridors that allow you to use tubular port-based systems with or without the assistance of an endoscope, or transventricular approaches through these ports as well. Or they can involve sort of mini keyhole craniotomies, potentially through unconventional incisions that may have cosmetic appeal to some patients, such as an eyebrow incision. Or, and in those settings, you may use the endoscope to look around corners if your exposure is not as wide as a standard terional or orbitozygomatic craniotomy. And so with that sort of definitional background in mind, what we can ask, what are some of the pros and cons of being minimally invasive? And these are sort of some of the things that have been thought about over the years. Obviously, the advantages of this would be smaller wounds would presumably heal better and heal quicker and in a more cosmetically desirable manner. Others have theorized that if you use these approaches, you'll be retracting less normal brain and also resecting less normal brain, and therefore this could promote less postoperative edema or better or quicker recovery of white matter tract function. Proposed disadvantages of these approaches would be for intraaxial tumors, particularly glioblastoma, which previous speakers have alluded to how invasive it is with tentacles. Would you really be getting a sufficient margin of resection? And there's a whole literature about whether we need to resect more than just the enhancing portion of high-grade gliomas, but if we should be resecting the flare. And once you try, can you really do that through minimally invasive exposure? And then another challenge or potential disadvantage with minimally invasive exposure would be hemostasis. And, if you get into some bad bleeding and are struggling through minimal exposure, would you need to urgently convert to a craniotomy, and would that put a patient at undue risk? So, with that in mind, we can ask, historically, if we argue that sort of minimally invasive craniotomy approaches are 1 to 2 decades old, endonasal surgery, which is sort of, historically what we thought of as minimally invasive surgery for brain tumors, developed by our pituitary colleagues dating all the way back to the time of Jules Hardy. We've learned a lot of lessons when we do endonasal surgery, and I've just mentioned sort of 2 things that come up when we talk about ports for brain tumors. So, one is that historically when the endonasal surgeons were using microscopes, they would use speculums to pass through the nose, and this protected the sinonasal passages from trauma and blood dripping down into the operative field. When we switched to the endoscope, people moved away from speculums because you were getting these wide, tremendous exposures. But more recently, there's the company, Speedway, that's marketing sort of endonasal sheets. And so the idea here is to protect the surrounding tissue much like a port or a tube would for a minimally invasive craniotomy. And similarly, the endonasal surgery, several groups, including Dr. Oyosiku at Atlanta, have pioneered the 3D endoscope, which sort of restores the advantage of binocular depth perception that the microscope would offer. And it's been really a nice tool for endonasal work, but the challenge is that the 3-dimensional visibility can cause the scope to become larger in size, and that can be an issue with smaller tubes on a craniotomy or a mini burr hole type resection case. So in the meantime, 2-dimensional exoscopes have at least improved upon the focal distances of standard 2-dimensional neuroendoscopes, and a lot of the studies I will cite rely on these exoscopes. So moving on, then the tools of the minimally invasive tumor neurosurgeon would really revolve around these tubular systems. 3 manufacturers listed here in the U.S. These were first used by Pat Kelly in 1987 in a frame-based manner. Sort of fell out of favor for a few years because they were linked to these frames, but the newer systems are frameless and actually allow sufficient working corridor for you to use bimanual dissection. The tips are atraumatic. They are compatible with standard frameless navigation, neuronavigation. Diameters come in a variety of sizes, and the smaller diameters have been used in several studies at multiple centers for transsulcal approaches to metastases and tumors like that. As I mentioned, the endoscope is also a tool for the minimally invasive tumor neurosurgeon. Rigid endoscopes can visualize disease, minimize retraction, and are small enough to be used within tubular retractors. The tubular systems that I just mentioned have diameters that are greater than the endoscopes while still permitting bimanual dissection. Endoscopes can also be used without tubular systems as part of keyhole craniotomies to see around corners in the setting of small exposure. And so what are the effects of the tubular systems on the surrounding brain? I mentioned this had been theorized as a potential advantage, and this was actually looked at quite nicely in a study from Journal of Neurosurgery just 2 years ago, where they compared the postoperative MRIs after tubular resection of a variety of pathologies to a sort of similar contemporaneous cohort from the author's institution that had undergone a microscopic conventional craniotomy type resection. And they found that the change in postoperative imaging flare volume was comparable between the groups, but there was more postoperative restricted diffusion in the surrounding tissue after the microscopic approach compared to the tubular approach, which at least offered some suggestive evidence that the sort of cytotoxic injury to the surrounding tissue was less in the tubular system than in the standard microsurgery approach. Of course, in order to protect the normal tissue, these approaches don't just protect the normal tissue without extensive foresight on the part of the surgeon, and many authors have mentioned DTI, but it is crucial when you do these cases, even more than a craniotomy, that you account for the DTI, because you really want one trajectory that will allow you to resect your lesion without causing injury to the tracts, whether it be optic radiations or corticospinal tracts. So those play a vital role in these cases.